Hello, everybody. My name is Sabine Wilhelm, and I'm a board member for the Society for Digital Mental Health. And I'm really excited to welcome you all to our Flash Talk session. Our topic is increasing engagement with and access to digital mental health services. And we don't have much time for our Flash Talks today. So we have about 8 minutes per person, but that includes you uploading your slides and everything. So we probably have about 4 to 5 minutes or so for each one of your talks. And then we have time also for a couple of questions. And I guess without further ado, I'm going to introduce our first poster. And that is entitled, I love that title actually, Digital Tools That Say Gay. And I think Eva and Nadia are going to present together. So if you want to kick it off.
Thank you. So Nadia and I today are going to be talking about a scoping review that we're working on, focused on digital mental health tools for sexual and gender minority stress and PTSD. So just a little bit of background before we dive into the review right now. Among LGBTQ+ individuals, the incidence of trauma exposure and prevalence of PTSD is higher compared to their cisgender and heterosexual counterparts. Sexual and gender minority individuals are subjected to ongoing stressors, which contribute to minority stress, defined as heightened chronic stress experienced by members of a stigmatized minority group, resulting from oppressive values, systems, and practices imposed by a dominant social group. And minority stress and PTSD are closely linked within the broader population, but specifically we have a lot of evidence for this link within the SGM population. Minority stress exacerbates PTSD symptoms, and there's also evidence that it produces PTSD symptoms even in the absence of a criterion A trauma, when there are experiences of oppression, discrimination, peer victimization that might not meet the DSM defined criterion A threshold. They still produce the rest of the PTSD symptoms. And this project is part of a larger scoping review that we're working on, focused on PTSD and minority stress interventions for this population. But we're particularly interested in digital interventions for this population. So that'll be kind of a large focus of this project. And this is for a couple of reasons. One is that sexual and gender minority treatment seekers often experience barriers to mental health care that further contribute to minority stress. So just the sort of systemic barriers related to minority stress, like experiences of discrimination, expectations of discrimination, concealment, management of a concealable identity, all of those things factor into overall general stress that they're experiencing, how much sort of time they have to seek out treatment, and the resources, the financial and time resources that they have available to them. And then additionally, within the healthcare system and the mental health care system in particular, which I think many of us may have witnessed over the past several days, the history and ongoing sort of oppressive experiences that people may have had in mental health care, that can contribute to more issues with engagement or the desire to seek treatment. So digital tools that use evidence-based strategies and integrate LGBTQ affirming practices may be a suitable alternative to traditional service delivery models or methods for SGM individuals who might be hesitant to engage with a system that has a history and exhibits ongoing oppression. So our research question for this scoping review is, what is the status of the literature on psychological interventions for sexual and gender minority stress and PTSD, particularly those interventions using digital delivery modalities? We have 5 primary objectives for this review. The first is to chart the data and sort of map out what the body of literature looks like. Two, identify potentially important intervention components based on the existing literature. Three, review the status of digital tools for sexual and gender minority stress and PTSD. Four, identify current gaps in the body of literature. And five, highlight areas for future directions. So the first step in conducting this review is establishing our eligibility criteria and developing our search terms and search strategy. So you can see from the inclusion and exclusion criteria here, which I won't go through in too much detail right now, we are being very inclusive at this stage of the research to try and kind of get everything that we can, because there is fairly limited data. There aren't, comparative RCTs testing like CPT and PE for gender and sexual minority individuals. So we're trying to capture as much as we can with this review. And then Nadia is going to pop on and talk about our search strategy.
Yeah, so we'll be running our searches in 4 databases, the first being Cochrane, then Embase, PsycInfo, and PubMed. We'll also be searching the gray literature. So we'll be looking at ProQuest for relevant dissertations and theses that are unpublished. We will search conference abstracts for relevant conferences for conference abstracts that may pertain to these topics. And we will also be hand searching special issues of journals and also any relevant specialty journals. After the full text review stage, we plan to search Google Scholar using their cited by function. So we'll also be checking the references of any of our included eligible articles to ensure that any articles that seem relevant made it into our search and was captured by that. Great, so this next slide is some of our search terms, specifically for our population terms. We develop these terms by looking at relevant journal articles, keywords, glossary of related terms, getting expert input, and also consulting with the health sciences librarian at Stanford University. So this is what our search string looks like for our population terms that was run in PubMed. And this is our treatment search string, which consists of relevant psychological interventions for PTSD and trauma more broadly, and sexual and gender minority stress as well. And these are our minority stress terms. This draws from the 4 components of minority stress, which is expectations of discrimination, expectations for discrimination, concealment, and internalized stigma. And these are our trauma terms, which consist of many common terms seen in the trauma literature, as well as components that characterize PTSD symptomology. And these are our outcome and our design terms, also seen very frequently in the literature as well. So this is our plan for data charting. So this is going to be an example of what this would look like. So we would count and categorize the number of interventions that are, for instance, digitally delivered versus non-digitally delivered interventions. And then whether they involve telemedicine or another delivery service option. And then breaking it down further by mHealth versus web-based. And then it will then be broken down into studies that have to do with minority stress, PTSD, or both. And finally, whether the intervention was self-administered, supported, or was a treatment companion. The caveat here is that there may be few studies that actually represent digital interventions for this population. And that's part of why we decided to do a scoping review on this topic. Great, so where we are now, so from our phase 1 search string in PubMed that I showed earlier, we ran our final search using the Boolean operators you see on this slide, and that yielded 414 results. So next step from here is going to be running the search in Embase, Cochrane, and PsycInfo, review keywords and checking for a priori identified papers that are relevant to the topic, and then adjust our search terms accordingly. We'll refine search terms and then run phase 2 searching in all databases, identify additional articles for inclusions. That's when we will be consulting with the gray literature and any special issues, Then we would do abstract screening based on eligibility criteria, which we'll be using the Covidence software for that. And then we will also be doing full text review at that after that point. And then we will be using the Google Scholar cited by search for final set of articles for inclusion and reference pages of final articles as well. And then conduct narrative review portion and data charting from there, see how many studies we got. Yeah, thank you so much for listening to our talk. Our contact information, emails, and Twitter handles are here, and you can also scan that QR code for access to our ResearchGate folder.
Thank you. This was just such an incredibly timely presentation, and I very much look forward to reading your review when you're done. I think we have time for one quick question if we have one. Okay, so there's just a comment, I think, but I don't see a question. It's way too long for a useful question. Okay, so we'll ignore that for now, but you can respond to the comments in the chat. So thank you very much, and we can move on to our second question, to our second presentation, and this is about tailoring the content of a digital CBT program to address the needs of diverse populations. And I see that Robert has already shared his screen. Very nice. And yeah, go for it, Robert. Take it away.
Perfect. Thank you so much, Sabine. Hi, everybody. I'm Rob Montgomery. Just want to make sure, can we see the slides?
Yes, perfect.
Perfect. I'm here today to talk about the process of tailoring the content of the STAN digital therapy program to address the needs of diverse users. There we go. This digital therapy program was developed over 3 years within the Innovative Treatment Network at the UCLA Depression Grand Challenge under the leadership of Dr. Michelle Krask. The program is part of the STAN system of care, which provides individuals with stratified, personalized, evidence-based treatment based on their specific mental health needs. Our focus today is on the creation of content for STAN digital therapy, a transdiagnostic modular digital therapy referred to as Project Rainfrog, which was designed to address a wide range of mental health concerns simultaneously with personalized content and interventions guided by a certified STAN coach. Now, there are far too many collaborators to name and thank. However, I do need to call out Dr. Zachary Cohen, who just posted that very long comment, the postdoc who is the driving force behind the development of almost every aspect of Project Rainfrog. He worked really closely with our project manager, Tom Christiansen. And together, they oversaw a team of 60 plus UCLA undergraduates, graduate students, and industry professionals. I had the pleasure of working as the multimedia content lead, and so was deeply involved in the process of managing content creation for this program. So let's discuss how we approach trying to make the STAN digital therapy content inclusive, equitable, and accessible for college students from diverse backgrounds. First and foremost, we turned to our actual stakeholders and co-developed the program with our target users using an iterative, dynamic, responsive, and stakeholder-focused development process. But what the heck did that look like? So the initial target users were UCLA students. So we conducted focus groups and collected feedback from UCLA students and peer coaches who were using a different existing digital intervention available through the STAN program. These students told us that the existing program lacked diversity and that they wanted to see more of themselves reflected in the content. So to address this and other needs, we iteratively brainstormed and developed ideas with stakeholders and subject matter experts. For example, we decided to use animation instead of live action videos. That would allow us to have greater control over how diversity was represented in the content and to set us up to be more responsive in the future without having to reshoot and re-edit live action video, which if anybody has done that is an absolute pain. So for example, as we adapt the program now for perinatal depression, we've been able to reuse much of the existing content by quickly swapping in pregnant character avatars. Another example is that we created an in-house production studio, hiring primarily UCLA students. And this would provide training opportunities, save us costs, and allow for student stakeholders to be directly involved in creating the program. Now, some of these challenges required many iterative brainstorming cycles to resolve. We'll go through a little loop here, for example. So one of the big questions is, what aspects of diversity should we prioritize in the program content? Really challenging. We started by attempting to design animated avatars that reflected the diversity of the UCLA student body as our target across many different aspects of identity, some of which are listed here. But that leads to another question. How do we represent all of these identities in a way that avoids tokenization? Well, we began by recruiting a diverse set of voice actors and then created avatars based on these real people, hopefully helping us to avoid some stereotypes. Another question is, how should we distribute these characters throughout this modular program? We, Zach and I in particular, spent hours making some truly insane spreadsheets to try and track and balance these avatars across all the possible combinations of modules, with the aim that users would see at least some aspects of themselves represented, no matter what version of the program they received. Now, we also had to dynamically respond during the development process when we partnered with East Los Angeles College, or ELAC, to pilot the program with their students. So the ELAC and UCLA student populations differ along a number of dimensions. For example, ELAC is majority Hispanic and Latino. Nearly 2/3 of the students experience food insecurity and over half experience housing insecurity. So we worked with ELAC students and identified a new set of needs and adaptations, including translating the entire program to Spanish, reconsidering the relevance of examples and narratives, standardizing the reading level of the entire program, and expanding the accessibility for those with different needs by following ADA recommendations like some of those listed on the screen. Now, there was so much more, but I hope these few examples help illustrate what we mean by an iterative, dynamic, responsive, and stakeholder-focused development process. Unfortunately, though, this kind of approach can be a real challenge for typical grant-funded clinical research, and for-profit organizations are often not financially incentivized to prioritize inclusivity or accessibility. We were able to do this because the DGC was supported by UCLA donors, the LA Department of Mental Health, as well as Beyonce's Bay Good and Jack Dorsey's Start Small foundations, which prioritize efforts to develop and disseminate high-quality, evidence-based mental health interventions for underserved and minoritized populations specifically. This highlights the importance of non-traditional approaches, funding sources, and collaborations, although this is obviously easier said than done. To wrap up, this was an eye-opening and humbling experience for us. While we're proud of what we were able to accomplish, we recognize that we've only begun to scratch the surface on what's needed to close the gap here. Nonetheless, we hope that by outlining our approach, we can provide examples that might inspire ideas in your own work to help fulfill the promise of digital mental health by ensuring not only its scalability, but its inclusivity and accessibility. Thanks to the entire Rainfrog team, not even all of which are pictured here. And thanks to you for your attention.
Wow, Robert, this was great. And I wish everybody would develop their digital CBT programs in the way that you do. So let's see, I don't see any questions in the chat. So I'll move us right along. Please, if you do have questions, post them in the chat. And if we have time, we can always talk a little bit more about specific posters in the end. So now we are moving on to our talk number 3. And this is on digital equity in mental health interventions and can a freely available meditation app reduce disparities. Oh, great. And you're already sharing. Okay. And we can take it away. Just kick it right off, please.
Hi, everyone. Can you hear me?
Yes.
Perfect. All right. My name is Zishan Jiwani, and I am presenting, just mentioned, can a freely available meditation app reduce disparities? So mindfulness and meditation practices have been found to be beneficial effects for a range of psychological disorders. And this is from a systematic review of, I believe, 44 different meta-analysis, which were looked. And again, it was found that mindfulness and meditation can be beneficial for a range of psychological disorders like anxiety, depression, etc. And what we also know is that 46 million people in the US have practiced some sort of meditation as of 2017. And this number probably during COVID has gone up given the number of different agencies and organizations that have promoted meditation as a potential tool to manage psychological distress. However, we also know from various surveys that certain demographic groups, such as white, female, college-educated individuals, are just more likely to utilize and access meditation. So the question is, can technology come to the rescue? So technology does a few things that allows for ease of access. So its meditation becomes more accessible. If it's delivered in app format, there's a lower financial burden. In our case, it's a free app, but in many cases, apps are generally less expensive than going to, say, a course to access meditation. And there's also reduced stigma, in part because there's privacy, so people can choose to do this in the privacy of their own home. So could technology reduce the disparities that we see? And so, again, that is our question, right? Can a freely available meditation app reduce such disparities? So we looked at the Healthy Minds program app, which is a freely available app. So anyone can download it on Apple or Google Play, the app stores. It's an app developed by the Healthy Minds Innovation, which is the nonprofit arm of the Center for Healthy Minds, based at the University of Wisconsin. And we had a sample of 35,000. We looked at 35,740 users. And we specifically focused on users that were based in the US, since we have demographic data from the US. We also looked at participants if they included at least one demographic variable. So in the app, it's optional. Individuals can choose or not choose to report their demographics. So we looked at individuals that had at least one. And so our total sample was 35,740. And we broadly asked two questions. The first is access. So we looked at the demographic proportions of individuals accessing the Healthy Minds program relative to their proportion in the general population. And then the second thing is we looked at utilization. So did these demographic characteristics predict their utilization positively or negatively? So once they're in the app, were females more likely or less likely to actually use the app? So this is a general sense of the users as well as the census data. And I'll point out specific ones. So as you can see, females represent about 50% of the population, but in HMP, we're about 71%. Again, education is another really critical one. So twice as many HMP users were college educated relative to the general population. Again, we see a larger proportion of white individuals, and significantly smaller proportions of African American and Latinx individuals who actually ended up using the app. And then we also looked at utilization. We ran a number of regressions seeking to predict three types of utilization variables. So we looked at individuals who downloaded the app and engage in any practice, any sort of meditation practice. We looked at the number of days of practice, and we looked at total amount of practice. And what you see here are standardized betas that show what the effect size were. So we can see being African American, for example, right here, led to lower amounts of utilization across all three of these practice variables. College education led to was probably a largest beta. So if you were college educated and you were on the app, you were just much more likely to use it across our practice variables. Interestingly, female, even though there are larger numbers of female that use the app, we did see lower utilization amongst female. And then also we see a slightly less utilization for individuals who were 34 years or younger. So what are some implications of these results? So one is technology doesn't seem to be that special, at least in this case of meditation apps. We see the patterns of meditation app we see outside in general context seem to extend to apps and technology, despite reducing ease of access, despite having, at least in this case, no financial burden. We still see sort of similar patterns. The second implication is college education is really important, at least in this context. It was both a strong predictor of even getting on the app, as well as once you're on the app, using the app. And one potential reason for that may be that the Healthy Minds program, the app that we use, is very research focused. So it talks a lot about evidence and research, and that may be just more appealing to college educated individuals. And then the last thing is being Latinx and being African American led to lower access, and then identifying as African American led to lower utilization. So as an individual, if once you're on the app and you identify as African American, it did lead to lower utilization, which is really important to think about how, and as I think some of the other presentations have mentioned, how do we really change this? How do we really shift this dynamic? And that's an important question, important next step in this research. There are a number of limitations we should also mention. It is just one app, so it's not, it's not representative of all apps, but it's one that we had where we had access to the data. HMP, again, as I mentioned, is research focused, so it may be appealing to certain population more than others. The effect sizes were fairly small, so they range from 0.01 to 0.15. Beta, so that is relatively small. And then a large proportion of users were missing. We had a lot of missing data, so that's also something to take into consideration, that users were free to choose to report demographics or not. So that's all we have. Thank you so much. This is my email, and my colleague Simon Goldberg is also on there, and we are happy to address any questions.
Thank you so much. And again, I wish everybody would just look at these variables that you are looking at in the same way. And I think you asked the really important question there at the very end, how can we really change this? How can we drive up utilization rates amongst African Americans? And I see there's already a comment or a question here. I see Antonelli, I need to wear my glasses.
Anatoly.
Anatoly, yeah. You have a question here. Do you want to just jump right in?
Yeah, thank you so much for this presentation. As a longtime meditator, I get a lot of value out of it, and I was really not even surprised, but it really drew my attention to it again, how much education has to do with it, with being able to access meditation. And so, Zishan, thank you for shedding the light on that. My question is, do we know anything about why that is?
Yeah, it's a really good question. And I also want to invite Simon Goldberg, if he's, there he is, if he has any thoughts on this. So one potential hypothesis I have, and this has also been found in other contexts as well, the other presentations I've seen, is that at times it may just be difficult to navigate the technological sphere when, like again, if these products and tools are being designed by college educated individuals and if that's who they're focused on, that the app may be designed in a way that's just easier for college educated individuals to access. So that potentially could be one reason, but that is something that's really important and worth exploring. I don't know if Simon, if you have any additional thoughts on why that may be the case.
I think it's a great question, and we're planning some qualitative work where we might be able to get at those questions a little more in depth. But one thing about the app that Zishan didn't mention that I think is important in light of the previous presentation, as well as there are options in the app to get instruction from teachers of different backgrounds. So we have done some effort. It's not nearly, getting at what Rob and Zach have been doing in the Rain Frog, which is super exciting. But there has been some intention to having representation of different groups in the instructors who are in the app. But I'm sure there's much more that we could do to kind of make it more engaging and have people see themselves really in the content.
All right, well, great discussion. And I don't see any additional questions, so then we can move on. And our next talk is about chatbots, and Eduardo is our presenter.
Okay, thank you. Can you
Yes.
hear me? And can you? Okay, good. So the title says English and Spanish chatbots, but it's mostly about Spanish ones. So I will present 3 studies on chatbots, and I will compare how some of these variables map to what happens in English chatbots. The first one is a small study on feasibility for a parenting chatbot. This was a study done with 0 funds, and in the free time from the research team. I am located at Palo Alto University in California, but I was working with a team of researchers in Argentina. This was a single session, and this is how the chatbot looks. And it was completed by almost 80% of the sample. The net promoter score was 7.44 out of 10, which is high. They did remember 3.7 skills out of the 5 skills that they learned in that single session. And this is a very interesting thing, that they exchanged 54 messages in just one single session with the chatbot, which is very high compared to the other studies that we have seen on chatbots for mental health. The main themes that they reported were that they were worried about the chat habits, handling disruptive behavior, and the usefulness of the intervention. I report this because I think this is a measure of meaningful engagement. It's not that they were just typing the buttons, they were also texting things that were relevant to them. The other study that we did is a follow-up of this one. It's a newer version of the chatbot. We call it like a micro-intervention for parenting that was aiming to teach parents how to praise their kids. Again, this was done with zero funds in our free time, and we recruited 170 participants, and it's almost 60%. 66% recruited, they were all recruited online, and almost 66% completed the intervention without having any compensation. All these studies are done for free in general, right? In terms of the results, 80% of the parents remember at least 3 out of 5 skills. The participants exchanged an average of, again, almost 50 messages in just one single session. This is, again, very high. Satisfaction score was 4.2 out of 5, and net promoter score 4.6 out of 5. And all the other acceptability measures were also pretty high, especially the one on usefulness for everyday life, in which it was 4.75 out of 5, right? So this is interesting to show how parents engage in one single session intervention. Now, we did another study based on a chatbot for anxiety and depression with university students, college students, we'll call it here in US. And this was a pilot RCT. Again, zero funds in our free time. Yes, we spend a lot of fun in our free times. And what is interesting here is that we randomized 180 participants. These participants were recruited in 6 weeks only, by just one researcher visiting the classrooms saying, hey, we have this study. If you're interested, join us in this WhatsApp phone number, right? You may say, hey, what's up, and research. In Argentina, there are no kind of legislations about what can be done or not in these type of things. And what we saw here was that at 8 weeks, 40% retention of the participants in, again, $0 compensated participants, right? So, and they exchanged an average of 116 messages, right, during this study. And they provided positive feedback, such as, you really understand me. And the more they used the chatbot, the more positive the feedback was. Now, when we compare these studies to chatbots done in English, for example, this study that we did on TESS, right? This was how people use the models for depression. We saw that after one model, most of them, they will quit. This is the kind of the participants flow across the different models that they can interact. All these models were based on depression. And the average message sent in this case was only 17. Remember that we had 50, 50, and almost 117. So what we see is that overall recruitment in Spanish-speaking countries such as Argentina was quick and at a low cost. The completion rate was high compared to what we usually see in the chatbot studies. And engagement, participants were more engaged than what we see in English chatbot studies. Sometimes they would engage longer, they would send more messages that had more text. And this is congruent with what Stephen Schuller and Adriana Aguilera reported on digital mental health technologies for underserved populations. So when we ask why people in Argentina were so engaged with the chatbot, it may be that our culture means that we're more open to share our kind of personal information. There's less concern about private information. There's no stigma about mental health. Actually, if you want to read some fun articles, you can read this one on GDP is depressed, but Argentina leads the world in shrinks per capita, and the rate of psychologists per capita is humongous in Argentina. And here we have another one on therapy is the norm, right? So we say that we have inverse stigma. If you don't go to therapy, there's something wrong with you. So basically a couple of things that we need to think when we develop chatbots in other languages, such as Spanish. We need to consider the linguistic, cultural, and research aspects. In terms of linguistics, there's a big problem that Spanish is gendered. all the language is gender. So emotions are different if you are talking to a female person or someone that identifies as male. To make it more clear, in English, you would say you're anxious, and that helps for everyone, right? In Spanish, you would say tú estás ansiosa with an A, that's for female, ansioso with an O for male, or ansiose if you want to have a non-binary language. So this means that you have to create kind of 3 scripts for almost everything, right? It's not that you just changed that last word. Another linguistical problem is the length. Spanish traditionally uses like 25% more text than in English. So this means that the chatbot that usually should be short sentences, it's more complicated to communicate an idea that is more kind of friendly to the users, right? And then there are regional differences. In some countries, for example, in Mexico, the word coraje means the opposite of what it means in Argentina, right? So emotions sometimes mean different things. And the way that you talk, if you use the second person of the singular you, in US may work for many individuals, but in Spanish you have tú, you have usted, and you have vos. And those 3 ways of communicating to the other person means that you have to change the grammar of the whole sentences. So you have all these genders and all these options of second person singular. So that is kind of a challenge. In terms of therapeutics, when we create chatbots, we have to think of what's the personality that the chatbot will have, because yes, users attribute human characteristics to the chatbots. Now, personalismo and familismo are core cultural Latinx values. So you want to create chatbots that may need to have more self-disclosure, share their origin. And we always start talking about where we come from when we meet other Latinx individuals. Maybe we need to be a little bit more informal. We need to share more emotions. When I say we, it's the developers and the chatbots. And it may be the case that the bond with the chatbot is stronger. This may sound kind of weird, but there are many articles showing that people create a therapeutic bond with the chatbot. Yes. In terms of research, there are some challenges. We have lack of resources, and there are almost no IRBs. On IRB process can take like 3 years to get just the initial response, right? So that is a problem, but at the same time, it's a land of opportunities, because there are many people in need that are open to use these type of resources. What we would suggest is to do recruitment through Latinx channels that can be trusted by Latinx individuals. And final considerations, people are using chatbots. The evidence is still at early stages. There are no large scale, sorry for the typo, no large scale efficacy testing. And we have the potential to reach a large population that has high need. Although Argentina has a lot of psychologists per inhabitant, all the other Latinx countries do not have that amount of psychologists. So I hope this is interesting for you. Thank you.
Wow, that was really great. And I'm so excited about the impact this work will have. We don't have time for a question right now. Maybe we have a little bit of time in the end, but let's move right along to our next presenter, and that's Rachel. And she will talk to us about an automated interactive text messaging study. Yeah, here we go, Rachel.
Great, thank you so much. So I'm really excited to share some of our work on behalf of myself and my co-authors listed here. And what we were trying to do here is design and develop an automated interactive text messaging intervention that is a scalable method to support the mental health of young adults. So I won't go into too much depth here, because I'm sure we're all aware of young adults' very high levels of mental health needs that are unmet. And we also know that many young adults are actually uninterested in formal treatments or unable to access them. On the other hand, young people regularly use digital technologies, mobile phones, and text messaging in particular. So the issue we're trying to address here is that a lot of the tools, the digital mental health tools that exist for young adults, have been designed with and for those who are already connected to formal care. whereas most young people actually are not interested or not able to connect to formal care. And they may have a different motivational profile and different needs than people who have been involved in design of most digital mental health tools. And so to address this, we partnered with a nonprofit organization called Mental Health America. They're an advocacy organization for people with mental health conditions. And they have a lot of traffic to their website, especially around self-screeners. So last year, about 5 million people went to their website to take a self-screener for various mental health conditions, depression, anxiety, etc. This is an example of results someone might see on the self-screener. They also reach a very diverse population. So in the US, it reflects the racial and ethnic diversity of the population and overrepresents young people, those with low incomes, and those in the LGBTQ+ community. They also know that most of the people that they reach are not interested in formal treatment, like I mentioned. So what we did here is we recruited directly through the self-screeners on Mental Health America's website. So the opportunity to participate was shown along with the screener results. And we engaged their users directly in a number of user-centered design activities, which I won't go into in too much depth right now. But really our idea here is that we can design tools that really fit within this specific implementation context and ultimately deliver them through Mental Health America and making these resources widely available outside the care system. So just a few findings to highlight about what young people are looking for in a digital mental health tool, and specifically an automated messaging tool. We found that they really appreciated the reach and convenience of text messaging because it's something they already use. Someone described, I'm always on the texting app, I don't have to open something else. So it was compared favorably to app-based interventions. They also wanted us to present tools as a scaffold for self-help. So they really resonated with concepts of self-help. And they were aware that they needed help, and they wanted us to be very blunt about our purpose. Here's a tool that might help you in your self-help journey, for example. And they really wanted diversity and variety. So they acknowledged, I get bored very quickly. I want to see new content. I want you to roll out new types of content, new interactions over time. And so this is both in terms of the psychological strategies that a tool would support. So we ended up building in many different strategies coming from CBT, acceptance and commitment therapy, positive psychology, and also they wanted diversity in the interaction types. So not just tips and suggestions, but also reflection questions, peer stories, opportunities to submit support messages to their peers. And really that bi-directional messaging was key to help keep them engaged. And they wanted agency to give us feedback, rating content, making choices, etc. And so this is, we've come up now, we've developed a text messaging tool. We're calling it Small Steps SMS. The next step is to conduct some trials to assess the efficacy of the tool, but basically what it does is send automated daily messages. It emphasizes diversity of content. It involves passive and active personalization, meaning people can make choices in content, and there's also machine learning behind it so that we can deliver more of what people like and engage with, and it will ultimately be made available through Mental Health America. So thank you so much for your attention. You're welcome to reach out to me with questions. And then I've also listed some papers here if you want to read more.
Wow, that was great. Actually, can you pop the papers in the chat too? Because I think that would be really fun for people to have for a little bit longer. Yeah, you know, I love how you, and actually also Eduardo in many ways, we're stressing the need to pay attention to the population, right? So that, I mean, you were saying when you have these text messaging system or when you have chatbots, that might work particularly well for the population that we are working with, which we said, well, with younger people, that fits really well into the fabric of their lives, right? Because they are texting all the time anyway, or Eduardo was saying, well, in Argentina, people like to interact in that way. You know, they like to chat, they like to go back and forth. And this is something that as a field, I think we have to just pay so much attention to, that people, you know, the treatment needs to be precise and it needs to be personalized for it to have the biggest impact. And let me see, is there a question? Are there anybody have a question? Nope, seeing none, then we can move right along to our next presenter. And this is now talk number 6, and it's already up. I love how you're going. Okay, Maria, then I'll turn it over to you.
Hi, well, my name is Maria Padilla, and I'll be presenting the attitudes towards psychological online intervention scale within a Hispanic community. Now, psychological online interventions are tools that are able to improve mental health access and equity, but as well provide confidentiality and privacy for ethnically minoritized communities. This is very essential because these tools could be used to improve other aspects of the field in psychology as well. With these type of improvements that they have provided, one could assume that they are both associatively positively with attitudes with individuals and being very well used. So to assess better these assumptions, the attitudes towards psychological interventions questionnaire was created, not only to examine acceptability towards POIs, but as well to look at user engagement and utility of these interventions. And this is very essential because these tools have the power to progress. And it is imperative that these existing measures are available in Spanish for minoritized communities like the Hispanic community. So we hypothesized 3 main points: that participants will report high comprehension of the Spanish attitudes towards psychological online intervention, and that participant ratings of depression severity and anxiety severity will be positively associated with attitudes of acceptability towards POIs and anonymity benefits. Recruitment method. So we had a total of 71 participants that consisted of 2 main groups: the SONA group, which is the recruitment method here at Georgia State University, and a community pool, which consisted of people in the Atlanta area and onwards. All participants had to meet 3 criteria. They had to be fluent in Spanish, be 18 years or older, and be of Hispanic descent. They all took the same questionnaire, which was completely in Spanish, and included measures that were listed here down below. Something I do want to highlight from our participants is the importance of where they came from. So they are majority or second generation, meaning that one or both of their parents are born outside of the US, and that majority could be assumed as native speakers since they have mentioned their principal language is Spanish. Translation method. So we use the forward and backward translation, which means we had 2 teams. One was a Spanish team that translated the English version into the newly developed Spanish, and then the English translation team that translated the new Spanish version back into English to assess the context and the meaning. Now, with this method of translating, we did keep in consideration the different ethnicities and dialects that make up the Hispanic culture. And to really assess that point, we made sure that our Spanish translation team was very diverse to be a good generalizable translation created. And something I do want to highlight when it comes to translation, it's not just on the aspects of the literal translation, but as well as keeping the context and the meaning of the original piece. So I do want to highlight in this example the word approach in this statement. If you have a literal translation of this word into Spanish, the closest word would be acercar, which would mean to get closer to. But if you look at this context, that message does not add up in the Spanish section. So to better assess this meaning, we use the word enfrentar, which means to face. That gives a better idea of what the original content is trying to say and keeps the message the same in both languages. Lastly, with results, the SAPOI did demonstrate questionable internal consistency, but participants did indicate strong comprehension of the translation. There were no statistically significant relationship between depression severity nor anxiety severity with attitudes towards POIs overall either. Overall, we were able to effectively demonstrate high rates of comprehension, but like mentioned, there was low reliability. This could be due to a limited sample size, which is something that we are working on now to further on the study and keeping in mind better recruitment, as well as looking into mindfulness of the linguistic diversity within the Hispanic community. This is something we want to share for further research and future researchers to keep in mind that even though the Hispanic population is one, the diversity within it is very big, and the linguistic aspects of it is as equally as diverse. And finally, the relationship of mental health symptomology and attitudes towards POI should be researched further among minoritized individuals and groups, because there is a lack of research even found for this study to better assess future research. And thank you.
Thank you. That was really outstanding. And I think we are all learning a lot about linguistics and the considerations that we have to make when we work in this space. So it reminded me a little bit of some of the things that had come up earlier, for instance, in Eduardo's presentation as well. So any thoughts or comments? You can take your slides down. Yep, thank you. Any thoughts or comments or questions before we move on? Let's see. No. Seeing none, then we can move on, and maybe we have a little bit of time in the end. And our next speaker is Joseph. Is Joseph here? With temporal associations between peer coaching and mobile mental health engagements for veterans in primary care. Let me see if we see Joseph or somebody who's covering for Joseph today.
Yes, here.
Yeah, great. All right, go for it.
And are my slides up correctly?
Yes, perfect.
Great.
Beautiful.
Okay, so I'm going to talk about, I think maybe something a little different direction from some of the other talks here, but hopefully an interesting exploration as well. Temporal associations between peer coaching and mobile mental health engagement for veterans in primary care. So what got me interested here is we know we have ample evidence that hybrid interventions integrating digital health tools with coaching or various forms of human interaction and support are a very powerful way to boost digital health engagement. And something we're still learning about is how. And in particular, I got curious about potential signal in the temporal relationships between app usage and coaching sessions in this case. And how we might detect that signal as a way of integrating the different data sources we have available. And this was a question that when I looked in the published literature, I didn't really see a lot out there on methodologically or in terms of findings. So this is just a kind of preliminary exploration of how we might look at this. And in particular, I considered three possibilities, very simple possibilities to start with. So one would be just that general proximity to a coaching session in time might drive increased usage. And then in particular, we could differentiate between whether usage of mobile apps before coaching sessions or after coaching sessions would be boosted, reflecting either anticipation of the coaching session or responsiveness in various ways to having had a coaching session. The study data that I used for this was a small single-arm pilot study that my colleague Daniel Blonigan will be presenting primary findings from elsewhere at the conference. And the intervention was provided to 39 VA primary care patients with positive screens for depression. Each of the patients was introduced to 5 VA mobile mental health self-management apps that I'll describe in a moment. And the primary care patients were also provided with 4 peer coaching sessions to facilitate app use over 8 subsequent weeks. And so these are trained VA peer coaches who also have lived experience of mental health issues. And the measures we're looking at here are objective app usage via in-app instrumentation, which we summarize in a heuristic way as visits which are separated by at least 30 minutes of inactivity, which gives us something resembling a session on the time scale that you might think of as like comparable to a therapy visit or a meaningful chunk of interaction. The apps provided to the veteran patients were PTSD coach, insomnia coach, mindfulness coach, aims for anger management, and mood coach. And these were all presented to the veterans to use as needed to address their mental health needs. And all of these apps are available free to the public. You can use the QR code and the link here to learn more about them and to download and install them, look at them yourself. I won't take time for a description of each of these apps here, but they all include learning modules, ways to track progress, symptoms, various kinds of tools that are tailored to the content and target of the app, and ways to get additional support. And here's an example of what the usage data might look like. So overall, we had in order to make sure that veterans don't encounter technical issues, in some cases we installed the non-instrumented versions of the apps. So we had a slightly smaller sample. Ultimately, we had 26 participants with instrumentation data, 17 participants with usage outside of the coaching sessions. On average, the patients ultimately attended between 3 and 4 sessions typically, with the interval between sessions working out to about 11 days on average, the target being 1 week between sessions at least. And then and they average, you can see in the distribution for the number of visits and the visit length that we had a very wide variation. Average number of visits to any app over the course of the study was 22, but with quite a large distribution. And then the same thing with visit length. So this would be kind of the number of events that were separated by less than 30 minutes in a single period. So this might be somebody coming in and out of the app. This is to account for the way that people use mobile phones, where they're not necessarily sitting in front of a single app for 30 minutes at a time, but they might be dropping in and out, getting a phone call, texting, coming back to it. So we kind of try to chunk that together in a meaningful way. And then below you can see example usage patterns. This is the top one is one of our heaviest utilizers. Using each color represents a different app. And so one square represents usage on a particular day. The vertical bars represent the coaching sessions. So we can see this top user consistently using a lot of the apps, insomnia coach most of all, but also a steady run of mindfulness coach. And we can see somebody who's closer to the middle of the distribution. I'm getting some significant engagement with the apps on a few different days, and then some of the low users who really might have dropped in just a couple of times. So how do we look at the proximity to the coaching? So this is something that really I was exploring methods, and part of the reason, part of my motivation to present this is actually to have a conversation with anybody else who's interested in this topic. I'm curious to know if others have explored methods for looking at this as well. So the approach that I took was in order to really have a strong hypothesis to test, was to divide the study period into equal length intervals. So to look at overall proximity, dividing into the half of the study period closest to the coaching visits, and comparing it to the half that was most distal from the study visits. Including, since we know that just any contact with study staff can increase engagement, we considered the study start and the study end as part of our multiversive analyses. Consider those to be potential contacts as well as the coaching sessions. And then for the anticipatory model, looking at the half of the study period preceding the coaching sessions most closely, and then conversely for the responsiveness model, looking at the periods following study visits or study coaching sessions or study contacts. And then the analyses here were firstly asking, is a given app visit, so collecting all the visits across all the users, especially as a way to kind of maximize the power in this small sample, asking, is a given app visit more likely to fall on proximal days in the red bars than on a distal day during the thin black bar periods of the study period across users, using logistic regression. And then And then collapsing all the users and looking across a 7-day window on either side of coaching, since that was our minimum separation between coaching visits, looking on a given day, is an app, are we likely to see higher usage count or higher usage duration on that day based on its proximity to the coaching session in either direction, whether it's either following or preceding the coaching session. And so using Poisson regression there, since we're looking for count data. The results are very simple. In this exploration, I did not find a signal, and I think that's still interesting. I actually expected to. So that's why I thought this would be kind of like an easy base hit analysis to do. Like, of course, they're going to use the apps more the day after or the day before the coaching sessions. And by the way, this is excluding data from actually during the coaching session itself, when we're expecting the coaches to be having participants go in and look in the app in order to orient to different parts of it and so on. So this is really looking at independent usage outside of the coaching sessions. This was looking across, as I mentioned, differentiating the initial, I didn't mention this part, but differentiating between the initial coaching session and follow-up coaching session, since that might be prior to the initial coaching session, they may not have been oriented fully to the apps yet. And then excluding the study contact at baseline and follow-up assessment as potential drivers of engagement, and looking across a few different metrics, so total count of app visits, duration of app visits, and also distinct days of app usage. So a few thoughts about this. Firstly, this is just kind of tackling the question of how do we integrate all the data sources we have available in order to better understand engagement, which I think is the topic that we all talk about and think about. And we have so much rich data, especially in hybrid interventions, that really, the question is, how do we make the best use of all of it? The finding, as I mentioned, there's no immediate signal that leaps out for temporal proximity to the coaching sessions. But again, that doesn't mean it's not there, especially in this small pilot sample, which was for me was the first sample I had available to test this question in, but certainly not far from the biggest and possible sample you could look at this question in. So one potential future step is to revisit this question as we gather more data and have more available in here at VA. And of course, there are many data sets that would be amenable to this type of analysis. And of course, another future step is to think about potential refinements to the method. One being that we do have available to do and that I'm looking into is the additional measures that we have in the data, characteristics of the coaching sessions, individual differences between the patients and so forth, and as well as analytic techniques to maximize the signal we're getting from this data. So I'll end there, and you can also feel free to be in touch. And also, I always like to just, I'm at the Dissemination and Training Division of the National Center for PTSD, so I always like to, I don't know what that is. Always like to also just provide information if you're a provider and you're interested in learning more about the apps. There are links here, and again, the links for the apps themselves. Thank you.
Great work, Joe. And unfortunately, we don't have time to go over questions here, but there is a question or then comments for you in the chat. Maybe you can answer them there. And I also want to point you to Emily Bernstein's work, who's also digging a little bit deeper into coaching, which is just such an important area, and that drives us, of course, drives up the cost of interventions. And I think we need to find out wherever that sweet spot might be. But last but not least, I want to introduce Kelly. Is Kelly here? If you can share your slides. And Kelly, is Kelly here? Yes, and Kelly will talk about optimizing digital health interventions for family caregivers. Okay, take it away, Kelly.
Great. Assuming you can see my single slide, okay? Awesome. Yes, thank you so much. So I'm Kelly Schaefer. I'm an assistant professor here at the School of Medicine at the University of Virginia. And I'm really pleased to be able to share some of this work with you all. And let's see, let's make sure we can answer. Okay, so contact information, I'd love to connect with you, and just to let you know that these slides and our study abstract are located at the Open Science Framework. I have no disclosures to report. As we've seen, 5 minutes goes past really, really quickly. So I just, if there's one takeaway that I would love everyone to have from my presentation, it's that everyone should be thinking about how well our digital health interventions fit for family caregivers. So why is that? About 1 in 6 American adults is a family caregiver, meaning that they provide typically unpaid medical, practical, or emotional support to somebody who's coping with medical or psychiatric illness. And for those keeping track at home, that's about 55 million Americans. So that's a lot of the population that we are hoping to reach. And the nature of the caregiving role can be really stressful. We know that caregivers in general have higher rates of anxiety, depression, insomnia, among sort of other concerns relative to the general population. We see from systematic reviews of sort of traditional care delivered by healthcare professionals in sort of in-person settings that interventions designed for caregivers have worked pretty well. However, they're just not accessible for this population that has a lot of scheduling and sort of life pressures. So enter digital health, and in particular, a cognitive behavioral therapy for insomnia program developed in our Center for Behavioral Health and Technology over the past 10 to 20 years. So I've been really interested in understanding how well this program that was designed for the, and developed within the general population, how well that might address the concerns of insomnia among family caregivers. So in the last major trial of shut-eye, that was actually the first one where we asked individuals whether they were family caregivers or not. And so it gave us an opportunity to do some sub-analyses. We found that caregivers in blue relative to non-caregivers in orange, they did show a reduction in their perceived insomnia severity symptoms, just unfortunately not as much as non-caregivers. However, we didn't see any differences between caregivers and non-caregivers in terms of satisfaction with the program, or how good of a fit, or how well they were able to follow it. And so we wanted to follow up on this and better understand how we could sort of improve this program for family caregivers. And so enter our really small scale feasibility study, sort of open label single group. And so I'll share a little bit of sort of our 8 caregivers who were caring for someone with cancer, who went through the shut-eye program. So again, we saw sort of pretty symptom reduction to a large degree in terms of the ISI, Insomnia Severity Index, as well as metrics from caregivers' sleep diaries in terms of minutes of sleep onset latency, as well as wake after sleep onset. And interestingly, we also saw some of the larger gains among caregivers who were sort of more recently providing care to an individual who is more recently diagnosed and providing more care. So that was sort of some interesting findings to us, suggesting that, again, caregivers can benefit from this fully automated CBTI program without any tailoring for caregivers specifically. So we followed up with caregivers and asked them to tell us, what are some things that you really liked about the program? What are some things that we might want to think about changing to make it even better for caregivers like you? We heard a couple of things. So if you're familiar with sort of the core cognitive and behavior treatment components of CBTI, caregivers really liked those components. So this quote comes from one of our caregivers, but you could see this. This is a kind of quote that you would hope from anyone going through CBTI, a very traditional response. As well as some of the daily components, caregivers, despite being really stressed and strained, were able to do those. They didn't always like them, but they felt like it was useful. And they also really appreciate the internet delivery, which is not a surprise given sort of, again, those scheduling and life pressures. But we did hear a couple of things that we might want to address for shut-eye, as well as I'm thinking about how these might be applicable to different interventions that you're working on. So addressing how sort of our target area, our target symptom is different for caregivers. For instance, we heard about sort of implications of addressing sort of nighttime symptom management, nighttime caregiving responsibilities. There were some concerns about impact of the behavioral treatment components, in particular on members of the family and particularly the patient. So the patient was a bed partner, not wanting to disturb them with stimulus control. Thinking about sort of how to address anxiety, again, so some of the comorbid stresses that caregivers are experiencing, as well as how we can continue to make our interventions even more easy for people to use. So for instance, including audio so that you can multitask, which caregivers are already doing, they told us. So we are following up these findings with a large scale trial that I hope we will be able to provide some feedback or data from that in the near future, in the next couple of years. And I'll stop there. It's just to thank the people and the funders who made this possible. Thanks so much.
Wow, that was great, Kelly. And Felipe Jain, actually, who is also at this conference here, also is interested in digital interventions for caregivers as well. So he might be a good person for you to look up. So.
Absolutely, thank you so much.
Okay, well, really, this was great. And we are out of time, but I just want to thank everybody for these outstanding presentations. I think we all learned a lot, and I hope to see you all at the wrap-up session, where David Moore will say goodbye to all of us and will hopefully encourage you all to join the Society of Digital Mental Health if you're not members yet. So thanks everybody for the great presentations. Take care. Bye-bye.